Welcome, everybody, to another exciting WooU event. This is the fourth part of our glaucoma series, and we're very lucky to have a good friend of mine, Dr. Gaddie, with us, and I'm so excited to hear his presentation this evening. My name is Dr. Stephanie Wu, and I am the host of the event tonight, and I am the founder of Wu University. And it's now my pleasure to introduce Dr. Gaddie. Dr. Gaddie earned his Doctor of Optometry degree from the University of Alabama, Birmingham School of Optometry. He then completed a residency in ocular disease through Northeastern State University College of Optometry. Dr. Gaddie is a fellow of the American Academy of Optometry and president of the Optometric Glaucoma Society. He has co-chaired the International Vision Expo meetings. I'm sure a lot of you guys have either been to Vision Expo. I'm sure everybody has heard of Vision Expo that's on tonight. And he's presented many educational lectures at meetings all over the world. In 2011, Dr. Gaddie was inducted into the Oklahoma Pioneers in Optometry Hall of Fame, and he was awarded the Kentucky Optometric Association Optometrist of the Year Award. Dr. Gaddie is a true expert in glaucoma, and so we're so excited to have him this evening. Thank you for joining us, Dr. Gaddie. It's a pleasure to have you tonight.
Well, thank you, Stephanie. And looking at like almost 800 participants, really proud of what you've done with this platform here and the education that we're able to provide to our colleagues in a very convenient manner, except when you're the presenter at end of a long Monday. I'm kidding. So with that, today, Stephanie asked me to talk about drug delivery and SLT. And these are two areas that in my own practice in Kentucky, and I know we have probably every state represented, we're doing these procedures in our offices. And so I want to kind of bring those experiences to you and explain why we really are starting to have a renaissance in glaucoma. If you look at all the therapies that have come out since 1996 was the prostaglandin analogs and Xalatan. It's been effectively a Me Too drug. It's either been a different prostaglandin, combinations of other currently available drugs. And then really just in the last few years, we've had our first new categories of glaucoma drugs with the rho kinase inhibitors and the nitric oxide drugs. But if you look at it as a whole, everything is moving towards how do we get the drug or the treatment to the point of the disease, which is the trabecular meshwork. And we're going to talk a lot about that tonight. And in particular, we're going to start talking about the only biodegradable, drug implant for glaucoma, which the trade name is called Durista, but it's an intracameral implant that goes, we'll talk about where it goes, but it does eventually go to the trabecular meshwork, to the angle. And that's where, again, the disease is. If you were to take a patient that has had glaucoma that you've been treating for 25 years and they're on a couple of medicines and they have moderate glaucoma, you would probably see pretty quickly that if you were to, take their eye out and do histological studies, the trabecular meshwork, the Schlemm's canal, the collector channels, the whole outflow system is really damaged. It's scarred, and there's a lot of adhesions. And so we think that a lot of these drugs help when we put them on the cornea and they get through the cornea, eventually into the anterior chamber and have their effect. But imagine what we could do when we initially place the drug or the treatment in the case of SLT at the angle. So the first thing we're going to talk about tonight is the implant. As you can see, it's very small. One of the smallest things that can go inside the body. If you think of some of the MIGS procedures, and I do want to bring up the MIGS, the minimally invasive glaucoma procedures that go along with cataract surgery. Those have really taken a huge increase in market share over the last 10 years. And I think one of the reasons ultimately is that it's targeting the site of the disease, whether you're bypassing the trabecular meshwork or you're using a device that tries to restore it, scaffold it, keep it in place. All these treatments we're talking about now are going to the angle. So with this, it's a very small implant. It's actually the concentration of the implant is the size of one drop of Bimatoprost. Okay, so think about that. We're taking one drop, the contents or the efficacy of one drop, and implanting it in the eye. And in many cases, it's working for months and years at a time without having to replace that particular implant. So that's how we're going to start. The indication, of course, is for patients with open-angle glaucoma or ocular hypertension. For me, it doesn't make a lot of sense maybe for ocular hypertension to go through implanting something in the office. The one exception that we have used it on is in steroid responsive patients. We have so many folks now that are having advanced corneal procedures, DMEX, DSEX, things like that require long-term steroid usage. And this happens to be a really nice option for some of those patients as well. So this is what the implant looks like on magnification. You can see the bolus. It's kind of porous, allows for the elution out of the actual implant polymer into the trabecular meshwork and anterior chamber. So when these are implanted, if you were to take your gonioscope out and look at week 2 here on the left, you can see let me see, make sure I have a pointer going here. Give me just a second. There we go. So here you can see the implant. As soon as it goes in, it goes to the inferior angle because of gravity, of course, but you can see the implant. Now, a year after injection, you can see it's a lot smaller in stature, but it's still there. By the way, all the drug is eluted out of this by 3 months. So there's not any extra drug effect, even though the implant you can clearly see is visible in a lot of cases. If you look down below in a second case, much smaller by year 1. And when you go to year 2, you can just barely see some resemblance of the implant itself. So to get this approved, they had to go through phase 3 clinical trials like all drugs. And so was this going to be considered a drug or an implant? There was a lot of debate about that. But in the clinical trial, they had 2 different randomized identical parallel groups trials. And it was compared to timolol 0.5%. And of course, that's what all FDA drug trials require today. And looking at the inclusion criteria, this is important when you begin to think about which patients might be eligible that you have in your practice. And first of all, you may stop and think, well, what patient is going to want a needle in their eye for glaucoma when they could take an eye drop, right? I mean, who would want to go through that? Same thing I would kind of ask you about, like, anti-VEGF, AMD drugs. I always thought, oh, my patients are going to hate this. They're going to be just mortified that they have a needle coming towards their eyes. And remember, they may get these every month for years. And very rarely do I have a single patient that tells me that their injection, their Avastin or Eylea or whatever the case may be, injection was just super traumatic. They really don't complain too much about it, surprisingly. You'll see the inclusion criteria greater than a grade 3 angle. And the reason is you have to have space for the implant to fall and to seat into place. What I tell doctors typically is if the angle is too narrow to do SLT, right? If you can't access the angle with your gonioscope, you can't really have an effective SLT. Same thing here. If it's too narrow for SLT, it's probably too narrow for this injection as well. In the clinical trials, you can see the pressure was between about 19 and 32. And they do look at corneal endothelial cell density. And the reason is this injection goes through the cornea, right? So we want to make sure that there's not something about this injection, the track that it takes through the cornea, that might somehow impair corneal function later on down the road. The exclusion criteria is equally important. You'll see non-responsive to beta blockers, but more importantly, non-responsive to topical prostaglandins. This is important if you've had somebody that you've had on a topical PGA and they just really didn't have much of a response, which isn't super common, but it happens. This might not be something you want to try and inject into the eye, right? If it didn't work topically, the chances that it's going to work intracamerally are pretty well reduced. So again, some people like to start their patients on a prostaglandin just to make sure they're going to respond before they go through putting this in the eye. What I can tell you so far with my own usage and experience is that I'm not really reaching for this for my primary therapy for patients that have never been treated. These are really for patients that have been on treatment. They can't take the medicine because of side effects, cost, just being able to remember to do it, complexity of the regimen that we have them on. And so as you'll see in the clinical trial, by inserting this drug into the eye directly, we really remove a lot of the side effects, topical side effects that we see with prostaglandin analogs. And we'll talk about those in just a minute. In the clinical trial, you can see in the Durysta or the Bimatoprost arm, 374 patients, same in the timolol arm, and the vast majority of patients are on one medication. And so the question is, is this to replace medication when you think about how you're going to use it, or we're going to take somebody on a PGA and replace it with this? Are we going to do this as an adjunctive drug? But in this trial, they're really looking at this as a primary therapy. So everyone's washed out of their regular medications before they enter into the actual trial. So this is looking at the first clinical trial, the Artemis 1. You can see about a 33% mean reduction, about what you would expect with a topical prostaglandin analog. One thing I might note is that patients that take the drop typically have a slightly better reduction of IOP than those that have it injected. But I would challenge you that the chances that your patient are taking their drops as prescribed every single day without missing them or having a lapse is probably pretty low. So even though it might be slightly less efficacious, the fact that it's in there, it's working 24 hours a day, there's no peaks and troughs, really does have an advantage. As we go to the Artemis 2 trial, there we go, the Artemis 2 trial, you see about the same thing, around 1/3 reduction in intraocular pressure, non-inferior to timolol, of course. And this is what I was referencing earlier, that the patients with adverse events, you can see conjunctival hyperemia with timolol is about 17%, but with the Durysta or the Bimatoprost, it's 27%. Now, this is something important to talk about because most of this comes from the betadine wash. So before you do the procedure, you put a speculum in, you do a betadine wash. We do it twice just to prevent endophthalmitis, right? That's really big concern whenever you're going to do an injection. And most of the hyperemia, if you've ever used any of these products for EKC or any other type of wash, it really does irritate the eye. The percentage of patients after the first 2 to 3 days that have hyperemia, extremely low. And if you compare that to like a topical, a Lumigan, a Travatan, Zalatan, whatever it may be, it is going to be much lower. There is a bit of a foreign body sensation, again, very transient just because of the injection procedure. A little bit of photophobia. Again, these are really small percentages. Conjunctival hemorrhage is typically related to the needle, the injection itself, or even the speculum. It's not due to the drug effect. And you can see that most patients really had no significant adverse events. About 5% had a headache. Again, you could prescribe aspirin, and 5% of people probably have a headache. Most importantly to know, you don't see anything at all about pigmentation. So this pigmentation issue we get around the eye with topical drops, maybe to the dismay of some of our female patients, there's no eyelash growth either. And I know that's a wanted side effect for many people, but by injecting it, that's really goes by the wayside. You can still get some iris color change because the drug is up against the iris. But in terms of hair growth and all the other loss of the orbital cell fat, deepening of the eyelid sulcus, all of these things go away effectively with the injection procedure. Just due to time, I'm not going to go over all these absolute numbers, but you can see in the red is the implant versus blue is the timolol, getting an additional 1 to 2 millimeters of IOP reduction. So we've already talked about a couple of these things. One other I'd like to bring up that we see with prostaglandin analogs when used topically is cystoid macular edema. And this really is in patients with a broken lens capsule, a traumatic mistake during cataract surgery, or patients that are aphakic, or maybe patients that have an anterior chamber IOL. Anything where you have vitreous loss, where you have the ability for the drug to connect with the vitreous, that's where you have the biggest risk of having macular edema. Again, not very common or even reported in this study. Of course, endophthalmitis, I've already talked about that. That's at the forefront of everyone that does an implant inside the eye, and certainly is a very, very top of my concerns. Conjunctival hyperemia we talked about, and as well as foreign body sensation. So what does this thing look like? This is a look at the actual delivery device. It's preloaded, and once you pop the cap off, you'll see a very small needle. It's a 27 gauge needle. And one of the challenges when you're learning how to do this procedure is trying not to bend the needle as you do the actual procedure. So really takes a little bit of practice on the angle to insert it, making sure that, you know, you're not placing the bevel in an area that could cause a problem, and discarding of everything. Once you do, you pull this little safety tab that you see right here, you pull that out, and now you're ready to go. As you can see in the diagram there, we want to go really to the temporal side of whichever eye you're going to do the procedure in. That one's going a little more into the eye than I typically like to go. I like to try and kind of stay at about this angle. And you want to go about 2 bevel lengths into the eye. You see the bevel right there. You want to go about 2 of those into the cornea. And that's where you press that button on that device that we showed. And we'll look at it. So here it is. You see the speculum in place. This patient is actually draped. Some of these are done in the operating room in the ASC because of the either the convenience for the surgeon or the patient, and also there's additional reimbursement when this is performed inside of an ASC versus in the office. But you can see they're making a clear corneal right at the limbus incision there, stabilizing the eye with a Q-tip there just to make sure the eye doesn't start rolling as we begin to deliver this needle into the eye. Following the release of the implant, you'll see it's fallen down to the inferior angle. Fortunately, that does not always happen. We'll go through a litany of things that can kind of go as not as planned during the procedure that can lead to some problems. But this is how you would expect it to look an hour, 2 hours after you implant it. Really visible at the slit lamp, but after a while, it's not quite as visible. So what are the things that we see happen? Let's see if I can. Got a video here, if I can make it work. All right, here we go. So this has been in the eye. Now they're injecting it, and whoops, it's stuck to the end of the needle. So what do you do about that? You know, you don't want to just yank this out of the eye and risk having that implant get trapped in the corneal tract. So one of the things you can do is just kind of, you know, wiggle it, let the fluid dynamics of the eye try and take it off of there. Sometimes you have to just kind of lightly drag just the tip of the implant along the surface of the iris will knock it off. But in general, they don't adhere to the tip forever. So that's one of them. And then another one you can see is where the implant kind of floats in the anterior chamber. So here it comes, it's getting ready to plop off. And instead of having a nice trajectory with gravity inferiorly, it starts kind of floating up. And so what do you do with those? Usually, if you have the patient sit upright, and typically we see this a little more in the supine position, like in the ASC, versus doing it at the slit lamp, just having the patient sit up, the vast majority of the time, we'll drag that down into the cul-de-sac and take care of it. And so here's an example of one. So what happened there? The doctor put the implant in. I'm going to play it one more time, and you'll see that they injected it correctly, but they pulled the needle out so quickly that the suction force of the removal of the needle sucked the implant back into the tract. So here it goes. If they would have waited just a second, that would have fallen off. And what you can do with these, they give you a special tool. It's a corneal tool where you can go in and kind of prod that and, you know, go through the track again and try and get it back into the anterior chamber. Occasionally in the clinical trials, they did have to do an anterior chamber wash to get these out. but most of the time, these are very uncommon occurrences. So with that, I hope everyone has an opportunity to begin to use or think about the positioning of that particular implant. The patients that we have been successful with so far are patients that just hate taking the drops. They hate the way they make them look. They can't, deal with the finances of it, the side effects, just being able to remember to do it. So this is a really nice option for a lot of patients. I also think about it very similarly to how I think about SLT, right? So we are delivering, the doctor is delivering the treatment to the site of the disease instead of the patient, depending on the patient, to put the drop in at the time we prescribed, at the frequency, the routes, all the things that we struggle with in glaucoma care. This really is something to consider and something I think you'll see grow over time. One of the limitations currently with the injectable Bimatoprost is that it's only indicated for one injection. In the clinical trials, they were injecting more than one, so over a series of months. And some patients even with a single injection were able to be controlled for over 2 years. Other patients, it only lasted for 4 months, right? So how do you know which patients are going to be, the super responders? And there's clinical trials going on right now to try and figure that out. But if we can really identify a patient type that, hey, Ms. Jones, I know you just been diagnosed with glaucoma. We're going to do this implant because it's going to be able to control you for, 2 or 3 years. That's really compelling versus what it's currently indicated for, which is just a one-time injection. We certainly expect to see that change. So with that, let's move to SLT, and we'll do a little bit of an introduction of SLT. In most countries, drops are still first-line therapy. If you look in the United States today, it's still probably 90% of patients start with drops. The problems are well known. You have to, how many times a year do we have patients in to check their pressure? And we're trying to really deduct how well their glaucoma is controlled based on an instantaneous IOP measurement. We're really at the same time holding the patient's hands, making sure they don't need a prior authorization or a rebate card or a medication switch or whatever the case may be. It's a lot of work for both the patient and the doctor. And so, the longer you treat glaucoma patients, you go from them having one medication to 2 medications. The next thing you look up, half your patients are on 2 or 3 meds, combination medicines. And, it can be a real struggle. And I think that's why we see a relative lack of ODs prescribing beyond one medication. I would say most of our docs in the US today are very comfortable prescribing that first, PGA or even a beta blocker. But when we end up on 2 or 3 drops, it does get complicated. And that's where I feel like some of these newer technologies can help keep the patients in our offices and let our ophthalmological colleagues deal with the more advanced surgical events that are bound to happen with this growing glaucoma population. So SLT was first approved by the FDA in 2001. Dr. Mark Latina in New Jersey invented SLT, or at least as far as I know, invented it. And what was great about it was, compared to the predecessor of ALT, argon laser trabeculoplasty, there's no thermal damage, there's no scarring, there's no pain most of the time. I would say out of thousands of these that we've done, I can only think of a couple of patients that even have said that it bothered them or that they had a problem with it. It's comparable in efficacy, especially as primary therapy, to drops. And we'll talk about a great new study that came out a couple of years ago looking at drops versus SLT. And probably the most compelling point I give to patients is that it's not permanent. We're not cutting anything. We're not burning anything. You're not going to smell hamburgers while I'm working on it. It is a laser that really, how I explain it is, it stimulates the body's own immune mechanisms to clean up the debris in the gutter, if you will, to clear up the leaves that are blocking the gutters and causing the pressure to go up. So with that, give me just a second here to move something out of the way. Okay. So let me move to the next slide. So why did we decide in Kentucky that we wanted to change our legislation back in 2011? This isn't to have a political discussion at all, but really highlights the fact that the Kentucky Institute of Medicine did a study back in 2010 that they predicted in the Commonwealth of Kentucky in the next decade, by 2020, which is today, that the eye care needs would increase by 80%. And I'm not sure that it really reached that rate, but if you think about a very rural state like Kentucky, most of our ophthalmological colleagues are in Louisville and Lexington, and we have a really large, long geographical state. And we have probably one of the highest rates of poverty, of blindness, of diabetes, we're number one in all the things you don't want to be number one with. So for us, it really made a lot of sense. And one of the main aspects was not necessarily, oh my gosh, somebody can't get a YAG capsulotomy. But for me, this glaucoma issue, being able to, improve patients' quality of life, save money for the system, and really have a better effective treatment for our patients was a driving force for why we went for that legislation. So just real briefly, the difference between ALT and SLT. ALT is a hot laser, a thermal laser, if you will, requires pigment to really have its effect, and it creates a scar. And so you put the laser scar ALT in there, it makes a burn, and by scarring, it pulls apart the adjacent spaces, and that allowed some outflow facility. Unfortunately, long term, it caused inflammatory membranes, caused scarring, and in essence was really just a last ditch before we moved on to a trab. Whereas today you take the SLT, it's a YAG laser, it's not an argon, so it's a cold laser. The YAG laser has a frequency of 532 nanometers. So if you're going to do a capsulotomy or a peripheral iridotomy, you're working at 532 nanometers. But when you use the SLT, they Q switch it or double it to 1064 is the effective wavelength. And by doing that, it allows a much quicker effect. So it selectively targets the pigmented trabecular meshwork without causing structural or coagulative damage. So what are some contraindications to laser trabeculoplasty? Of course, narrow angles. I already mentioned this. If you can't access the angle, it's tough. And I'll be honest, even in patients that have open angles, sometimes we do pre-treat the morning of the procedure with pilocarpine just to make sure we're able to fully access it. We're going through all this. We got the patient there. We have the laser there. Let's make sure we have a good effect. I would say about 80% of my patients I do without any type of low-dose pilo. Brimonidine we use to blunt the IOP spike, and brimonidine has a small miotic effect as well. And so vast majority of patients I can get through without it. Any type of inflammatory glaucoma, probably not what you're looking for. This is going to have an inflammatory response, so might not make sense. Congenital neovascular glaucoma, angle recession, someone that doesn't actually have glaucoma. And here's what's really important. If you have someone that really needs to pressure down quickly, this does have a fairly fast effect, but it's not going to get it down in an emergency situation. And the second piece to that is that if you have someone that presents with a pressure of 40, don't expect to be able to offer SLT and get to an acceptable IOP. It's going to take more than just one drop, one laser. It's probably going to take a combination of laser and eye drops. So this was a big one for me, and one that I really try and pay attention to, and that's looking at the visual field before I do a laser. If someone has a visual field that looks like this, we have fixation, split, the mean deviation is almost 17 decibels. This is someone with advanced severe glaucoma. If you do the SLT and they're an unfortunate patient that has an IOP spike, guess what's going to happen to the rest of this visual field? It's gone. So I think there's some clinical legal responsibility there. And frankly, when you have someone with this degree of glaucoma, laser trabeculoplasty is probably not going to get you where you need to be. This is a surgical glaucoma patient, a trab, today for me, a tube, maybe a Zengel implant as a stopgap measure, but most of these patients ultimately are going to need a tube. So with ALT, let's see if I can go back to my laser pointer here. With ALT, you see that this is the trabecular meshwork. And for this, you're supposed to have it in the posterior 1/3 of the pigmented trabecular meshwork. And I always used to tell students, if you can point that out to me, I'll give you $5 because it's impossible clinically to see it. And that was, one of the issues. You really had to have excellent placement. When you compare SLT and ALT, you can see with ALT, we had to leave all those spaces in between because of the scarring effect, because of the adjacent flow target. With SLT, we just kind of overlap them. My friend Tony Riolini, a glaucoma specialist in West Virginia, always jokes that when the patient, the laser, and the doctor all get in the room, it's going to happen. With SLT, it doesn't have to be in that precise exact part of the trabecular meshwork. We're just kind of overlaying the whole TM. The only thing you really want to avoid is hitting, of course, ciliary body, anything close to the iris that's going to hurt the patient's going to feel it. It's not necessarily going to result in synechia or inflammation or anything more, but the patient may notice that you're not right on target there. So one of the things I like to show with SLT versus ALT, on the left here is an ALT crater shot, and you can see this big infrastructural change, a big hole, literally a crater. Whereas on the right side, they've had SLT, and you really can't tell any infrastructural changes that have occurred. Before you can really get good at any type of laser procedure, you really have to know where you're looking. And so I always like to spend a minute or two on gonioscopy. I know it's everyone's favorite clinical skill. And, we see students and residents in our practice, and one of the things that doctors and students aren't great at is gonioscopy. And the reason is they only do it when they need it. So what does that mean? That means you have a patient with a narrow angle and you can't decide if they're going to go into angle closure. You throw up your gonio lens and you go, oh crap, what am I looking at here? Wait a minute, what is this open? Is it closed? And so I will tell you that if you want to anticipate future scope laws, if you want to be involved in treating glaucoma, MIGS procedures, you got to be able to look in the angle. Please get good at your gonioscopy. It is still probably a $40 to $50 reimbursable procedure. The cost of goods for it is extremely low, but the information you can glean from doing gonio in glaucoma is just invaluable. If you don't know what's in the angle, you really don't know what type of glaucoma you're dealing with. So here's someone, and we are looking at their inferior angle, and that means that the mirror that I'm looking through is the superior mirror. So superior mirror, inferior angle. You can see the iris, you can see the trabecular meshwork, you can see Schlemm's canal, and not really much of Schwabe's line. So if we're going to do a laser, it's going to be right through here. I love seeing that pigment. That tells me they're probably going to have a great response to SLT. But when you think about the angle, just keep in mind that the deepest part of the angle is going to be, I'm sorry, I screwed that up. This is superior angle, inferior mirror. The deepest angle is going to be the inferior angle. The most shallow angle is going to be the superior angle. Sorry for screwing that up. Now here's an inferior angle. So we have the lens in the superior component. You notice how this is the same patient, how there's much more pigment in the inferior angle than there was in the superior angle. And the reason is, first of all, gravity, right? Gravity is going to pull a lot of that pigment down. This patient has pigment dispersion. And so being the deepest angle and also the gravitational effect tend to see more pigment inferiorly. One other thing I like to talk about with gonioscopy is looking at the ciliary processes. So here's the patient's iris, here's the ciliary body, and then here's the trabecular meshwork. And these little finger-like processes right through here, these are the ciliary processes. And what they do, they start in the ciliary body and they course over and land on the trabecular meshwork. So if you have a lightly pigmented angle and you're kind of confused about where you are, all you have to do is look for those ciliary processes and it'll save the day. I use them all the time during SLT because sometimes you get an angle like this where it's so dirty with pigment, you can't even tell what's TM and what's not. So sometimes I'll just look for a couple of processes, like I see one right there, right in that area. maybe another one right there. And as long as I can see one of those, I know where I am, I can stay on track, stay in that trabecular meshwork. Here's an example of a patient with pigmentary glaucoma. You can see a lot going on. Here's the iris. Here is the ciliary body. And then here is the TM. And you see all these little finger-like projections. That is telling you that this is the TM. A lot of people might be tempted to think this pigmented Sampolices or line here is the TM, when in actuality, these trabecular or iris processes show you where the trabecular meshwork is. Sometimes you can get a very light colored trabecular meshwork and a full colored ciliary body. So you really got to pay attention where you are. If you've seen one angle, you've seen one angle. And when I'm doing SLT, I really try and stay focused on where am I? Every application, I stop, I put the laser down, I refocus. Am I where I'm supposed to be? I kind of talk my way through it the whole time. If not, you can get lulled into being in the wrong position with the laser. So what do I think about in terms of setting the laser for those of you that may, work around one or use your own laser? What we're looking for is 0.8 to a 1.0 on the power. Very rarely do I go higher than that. There's been maybe a few times in very fair complected patients with very light pigmentation of trabecular meshwork. Maybe I have to go up to 1.1. But in general, I start at 0.9 and I see if I get the champagne bubbles. If I do, it's plenty of energy. If I feel like I'm not seeing that reaction, I might go up to 1.0. I would guess most of my patients with my laser, I go at about 1.0. The spot size is fixed at 400 micron, and you have to use a lens. So that, again, is, I know a lot of people don't like using the 4-mirror lens for routine gonioscopy because you get, wrinkles in the cornea, and it takes a lot of dexterity and practice to be able to get a great view with that. Whereas this with SLT, we're using a standard like gonio lens. So it's got gonio cushioning agent. I use GonioVisc or Celluvisc. I've been using mainly Celluvisc because some of these other solutions have been on back order since before the pandemic. So I do like to use a lens. I'll talk about which one in just a minute. Just as some, historical perspective, there in Europe and in parts of Asia, they have done SLT without any lens, where they just do it on the limbus. So you just sit at the slit lamp and the doctor just paints the laser 360 around the limbus. And in fact, there's some new laser technologies that are in clinical trials that your technician, you basically put this device on the eye, this laser device on the eye, and it does the entire SLT in like 3 seconds. So you want to talk about game changers coming up. Instead of having to set the patient at the slit lamp and go through a 5-minute procedure, just have a painless, 3 to 10 second boom, and it's done. Also, a lot of discussion about 360 degrees or 180. Because of the global period, there are a lot of doctors that do 180 degrees and then bring the patient back and do another 180 degrees after the global period, because it can, you can bill twice. For me, I'm busy enough. I want to get the patient taken care of. I do 360 almost exclusively. I can't really think of the last time I did a 180 or a 270. I just go ahead and complete 360 and get that over with. This is an example of a combo laser. I have 3 different lasers that deliver SLT, and it's nice to have one that's combined, that if you want to do a capsulotomy and you also have SLTs, you're not having to have different lasers and issues. The downside to having a combination laser, if one goes down, you're down both of your lasers, so not always ideal. Preoperatively, you always want to look at the angle. I get a lot of referrals from my internal doctors and other doctors around our practice for SLT. And, it's tempting just to say, okay, let's go back to the laser and start. I always want to see what's in that angle. Like, I want to know what's in there. I don't want to see a big chunk of synechia or neovascularization or a cyst or something in there while I'm doing the procedure, because who's to say that I didn't cause that, first of all. Secondly, I want to know if there's a contraindication. So always look at the angle beforehand. We traditionally use brimonidine. Iopidine is pretty expensive to get. I have plenty of samples of brimonidine. I do 1 drop before, and typically we do 1 drop afterwards, just prophylactically. And then there's 2 different lenses. This is the Mark Latina lens. As you can see, it has 1 gonioscopic mirror. So when you put it on, I usually always start, this is really important with SLT. You want to make sure that people really get confused when they get the lens on and they get behind the laser. Like, okay, this is the patient's right eye, my left hand, my left eye, patient's right eye. Do I go clockwise or do I go counterclockwise? And people get really cute with this stuff. You don't have to. All you have to do is I start the same thing, right eye, left eye. I don't care what eye it is. I've started at 12 o'clock and I go clockwise around the eye, whether it's the right eye or the left eye, every time the same way. That way I'm not trying to guess, and I don't want to retreat an area. And I also don't want to leave an area barren that needed to be treated. So with this, after about 10 to 15 spots, probably about 10 applications, then you got to turn the lens. And it's important to find a ciliary process, a chunk of pigment, something that when you stop and you got to turn the lens, that you don't forget where you left off so you can start back. So I'm always, before I go to rotate that lens, finding a landmark, lining it back up to start back my trail of laser. The other lens that we have was actually John McCall, an former AOA president out of Texas, developed this lens, and it has 4 mirrors on it. And therefore, you really don't have to turn the lens at all. And it is kind of a pain. You get the gonio visc on there and you're trying to turn it with one hand and it gets a little slippery. So I usually stop, use my other hand to make sure I got it centered and go back and focus. With this, you really just got to do just a micro turn to get the 360 degrees of the angle. My only criticism of it, if you want to call it that, is that it's a smaller image because we have 4 mirrors instead of 1 large one. And some angles, I like a larger perspective, but in terms of speed and rapidity and, just ease of use all the way around, it's a nice addition. So good job, John. All right, we talked about all this. So here's a video of some laser here. And you'll see this bright red light there as we get started. There's the TM, probably a couple little ciliary processes there. And, going pretty fast there. Now see, don't have to using that 4 mirror. See how we had to go up in magnification because the image is smaller. But again, trying to each one. Now the video isn't always intact in sync with what you're seeing out of the oculars of the surgical scope. But you can see it going along. And so basically, if you don't die of boredom from going all the way around the eye, it is a pretty easy process. We keep patients for about 45 minutes to check their IOP. One of the only adverse events, of course, is a IOP spike. The trial we're getting ready to look at here at the end has shown that there's really a low risk of having an IOP spike. In fact, they advocate that you don't even have to keep the patient. Just being, NOD, performing the procedures, I want to make sure I take every precaution necessary. So I still keep them from 30 to 45 minutes. It's really, I don't know, maybe 1 in 20 years have I seen an IOP spike that's been significant. We do predacetate every 2 hours for 2 days. Now, why do I do that? Well, the surgery center I used to work in and do my lasers, that's how all the surgeons did it. So I just adopted that. In reality, there's no difference between no postoperative drop. So just you do the laser and you don't give them anything, or using an NSAID or a steroid. So for me, it's really a little bit more about comfort. In third world countries where some other groups are doing some SLT projects, they go in and they do SLT on an entire community who can't get eye drops, can't get steroids, and they just send them inside and tell them not to come outside for a couple of days, to sit in the dark until the inflammation subsides. So for me, that every 2 hours for 2 days works, but there's no absolute right or wrong way to do that. And then, some of the considerations, when do you use it? Going back to the same discussion we had with the injectable glaucoma medicines, are we using it as initial therapy? I can tell you, based on the study we're getting ready to look at, I strongly offer and recommend SLT as primary therapy, just because I know what it looks like 20 years down the road. And I know the efficacy and really how much better it does at managing the glaucoma. But more likely than not, I have more patients on medicine already than I have that I'm starting on medication. So it becomes more of a, if you're tired of taking your drops, let's do this. More often than not, it's usually you need a second or third medication. Instead of that, let's do laser. So let's move on to our last little section in the last 5-6 minutes here. That's talking about a study in the UK, and it was a study to look at first-line treatment for ocular hypertension and glaucoma, newly diagnosed patients. They were randomized to receive either eye drops or laser trabeculoplasty. So there are 1,718 patients, or over 1,200 eyes. And so as you can see, about 360 of each SLT and drop patients enrolled in the study. Hopefully you can see some of these background demographics. Ethnicity was largely Caucasian, mostly open angle versus ocular hypertension. And you can see some of the other characteristics there. Looking at the intraocular pressure on average in both groups, it was 24.5 in the eye drop group and 24.5 in the SLT group in terms of pre-treatment IOP. And so basically, think about this study. This is the first study that truly randomized, clinical trial, multiple sites, masked, had all these different components to it to see, which is better, drops or laser. And some of the endpoints were if someone progressed, if they had to add on medication, if they had to escalate to surgery, those are the types of things. But more importantly, the study looked at what percentage of patients with a single SLT or a single medication get to target pressure and stay there within 3 years. And sorry, I'm skipping through some of this. Some of the drug classes, most patients were started on prostaglandins, second line beta blockers, topical CAI. You could do fixed combinations, probably very similar to what you would see in clinical practice. So let me go back one. The outcome measures, first of all, were to see if this had an improvement in the quality of life, right? That's really what we think about in glaucoma. We have this disease which doesn't have any symptoms. They come in and now we're torturing them with eye drops, making them look like hell, and telling them at least they can still see. And they're like, but I can see fine. So we know this quality of life issue is big. It's difficult to measure improvements in quality of life in clinical trials, especially clinical drug trials. But that was the primary outcome measure. And the secondary, having some trouble here. Secondary was cost and effectiveness, the effectiveness of SLT versus drops, and the safety of SLT versus drops. Slides just are not advancing all of a sudden. Okay, overall, 95% of the SL treated eyes were at target at 3 years. Think about that. 95 out of 100 that received SLT as primary therapy were at target at 3 years. And in that arm, almost 80% were treated without medication, meaning they didn't need a rescue medication. They didn't need retreatment with SLT. So over 2/3, nearly 80%, 8 out of 10 patients were there with a single SLT treatment, which is pretty impressive. The medically treated eyes, about 93%, which isn't bad. And you got to remember these are people in clinical trials, so they're not, these might not represent the patients that you and I see in an average day, but at 3 years, after 36 months, 94% in the SLT group were at target pressure and 93% in the medication group. As you can see, progression-wise, 36 eyes in the medication group showed algorithm expert confirmed progression, whereas only 23 eyes in the SLT group showed progression. And this is at a 600 and something eyes in each arm, so very low numbers of progression. And only less than 2% of patients required surgery, and none of the patients in the SLT group progressed to needing incisional glaucoma surgery, importantly. So cost of therapy, this is really important. The money saved in the healthcare system, and this is in the UK, might not be the same exactly as it is here in America, but the cost to the system for every one SLT that was performed, the cost savings over medicine was enough savings to do 2 additional SLTs on other patients, making it almost 3 times more cost effective than drops. Again, difficult to extrapolate to the US market, but again, the eventual need for surgery, a trab, a tube, cataract, was significantly less in the SLT group than the medication group. This goes back to when I was a resident. Larry Alexander told me one time, I don't know if you all remember Larry, but Larry said, Ben, if you treat enough patients with glaucoma medicine, you're going to have a great cataract practice. So there's this notion that treating with a topical glaucoma agent led to a quicker development of cataracts. And I got to tell you, it seems, maybe it's just stuck in my head, but it seems to be a thing. So there was no significant increase in health reported quality of life. However, the secondary endpoints were really significant. You can see approximately almost $500 savings per provider-related visits. And looking at rate of progression, about double, 5.8% in the medication group versus 3.8% in the SLT group. Again, a compelling reason to consider it. And the IOP control was equal, except the diurnal control was better. And so there you go. SLT provides better diurnal IOP stability. So with that, I am going to move on to my last slide here. And I'm going to let Stephanie come back on. Dr. Wu.
Wow, thanks. Thanks, Dr. Gaddie. That was super, super duper informative. And I think it's just so important because so many people just immediately think of eye drops for glaucoma, and they sometimes forget, or maybe they just don't know about all these other treatment options. And you practicing in Kentucky, you have so much of a wonderful scope of practice there. So you're really able to really offer patients something at this really high level. So it's really, really impressive.